Welcome to an MS Views and News Summit. All right, this is called the MS Summit Denver. My name is Stuart Schlossman, not Denver. I want to let you all know that this event is sponsored by numerous pharmaceutical companies tonight, and I wanted to let you know who they are. We have Bristol Myers Squibb, Genentech, and Sandoz are all sponsors of the program itself. And our exhibiting sponsors, we have Alexion, Biogen, Bristol Myers Squibb, Genentech, Ecometrics, because I always say it wrong, Novartis, and Sandoz. And then we have in-kind sponsors, the National MS Society from this great area of that we're in right now, and the Rocky Mountain MS Center all helped us to provide tonight's program. Let's give them a round of applause. All right, so what we're going to be doing tonight is I have a series of questions to ask the different doctors, and they each have to answer the same question, but it's going to be asked in different order each time, so that way the same person doesn't get the benefit of the question. What I do need, though, is everybody's bios. Here we go. All right, so first, I'm going to tell you about Dr. Calkwood. Dr. Calkwood and his MS care team recently relocated and rebranded the MS Center in Minneapolis for the Minnesota Center for Multiple Sclerosis. It is a noticeably recognized MS neurology and neuro-ophthalmology practice in Plymouth, Minnesota. Dr. Calkwood is a neurologist and neuro-ophthalmologist with over 30 years of experience in the clinical management of multiple sclerosis. He's an active clinical trialist as a principal investigator and has published or presented over 40 research contributions in the field of MS. That's Dr. Calkwood right here. Raise your hand. Thank you. All right, next, Dr. Mitzi Williams is a board-certified neurologist and a fellowship-trained neuroimmunologist. She's the founder and CEO of Joy Life Wellness Neurology Clinic in Atlanta, Georgia. Her mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. And you can recognize who Dr. Williams is. And then Dr. Samuel Hunter. In his 40th year as a medical care for neurology, Dr. Hunter is in his 40th year of medical care for neurology patients with MS and related diseases. He is known for skills in using basic neuroscience in practice. He was an expert in medicines before he was an expert in MS. He has worked in Nashville for 25 years. Now he works to get to MS as early as possible and crafts lifelong plans to reduce disability from multiple sclerosis. Best known for communication of complicated neurology matters, but he is an expert in neuroimaging of MS and research. His greatest love is history of medicine. So let's thank them all first for being here, because they are about to get grilled. All right, so I'm going to start with Dr. Williams first. Now,
why'd you
please
pick on
know,
me?
What's that?
Why are you picking on me?
Because you stared too hard. All right. First, everybody should know that you're going to have 90 seconds each to answer this. And I need you to do your best by looking at that clock over there and seeing where you're going to be, because I can't be a guardian over here and making sure that you're sticking to it. So I'm going to ask, by the way, I'm saying this to these doctors because they are all extremely wordy when you get them started on anything, all right? And now they're going to be cut to 90 seconds or 60 seconds or whatnot, and it's going to be difficult. So, all right, starting with Dr. Williams, let's talk about progress. Maybe you can each share with what you find to be the most remarkable progress in the treatment options, diagnostic tools, and management of MS today versus years ago. So first, can you discuss more about the BTK inhibitors?
Sure.
You have 90 seconds.
90 seconds. So I think it's very exciting, right? So this is a newer class of drugs. There are several that potentially would be coming out in the next couple of years or so. And I think the exciting thing is that there is the potential for very high efficacy or very effective drugs with maybe a little bit less of some of the side effects. You know, many of the things, particularly with COVID, that we were concerned about was immunosuppression, risk for infection, things like that. And so I think that this is a really exciting pathway that may be very convenient for patients and treat their MS very well.
That was a quick 90 seconds, but thank you for that. Dr. Calkwood, you get the same question.
Thank you. So yeah, the BTK inhibitors are really, really interesting. Burton's tyrosine kinase. It's not only a new class of drug in MS. A class is a drug like the interferon drugs. Interferon drugs all worked in the same way. Avonex, Betaseron, Rebif. They all worked in the same way. Similar side effects. BTK drugs are going to be a little different for us. They work on enzymes. They work inside your cells on enzymes. And it's a completely different thing than anything we've had in MS. They also impact a slightly different aspect of the immune system. So the immune system is divided up into an innate and an adaptive immune system. Your adaptive immune system is the part of your immunity that learns when you're exposed to a virus or a vaccination. COVID would be a really good example of all that. So the adaptive immune system learns. The innate immune system out of the box is ready to go. None of our MS symptoms, none of our MS treatments, none of our MS treatments have ever impacted the innate immune system before. And there's some very important immune cells in innate immune system that are important to manage MS. So we're excited about the category.
Thank you. Dr. Hunter, your turn.
So this group of medicines is a new kind of anti-inflammatory strategy to calm down many parts of our immune system like never before without suppressing our ability to respond to infection. It's a new way of looking at things. We're still learning how it works. We're hoping it's better than what we used to have. We're sure it's better tolerated than what we used to have. But you're going to hear lots about it, 3 or 4 years from now. But we're in the process of major studies that are helping us learn whether it's going to be better. Where we are now, 30 plus years down the road from MS therapy is we keep coming up with better ways to skin the cat. And we're hoping this is the next one.
Thank you very much.
Oh, I need to add something since my 90 seconds
right.
wasn't up. I think another exciting thing is that there's a potential for some of these chemicals or the drugs to actually penetrate or cross into the central nervous system. And so this is also a novel or a new concept because most of our drugs work in your bloodstream, right? Which is where we get all the other side effects because they hit different receptors or different parts in different parts of your body. But the fact that this may actually be able to get into the central nervous system is very exciting. And so we're looking forward to seeing the results of that.
Thank you for that add-on. All right, next, Dr. Calkwood, you first. Please share with us what you find to be the most remarkable progress in the treatment options and diagnostic tools from today versus years ago. 90 seconds.
Yeah, that's boy, there's a lot. There's really a lot. So to pick a few. So I guess let's take treatment. So I think probably one of the biggest developments recently is in terms of new drugs, B-cell therapies. So recent new class of drug in a similar way that we're excited about BTK inhibitors hitting the innate immune system, B cells, first time we ever had any treatments that directly worked and primarily worked on B cells. So that was really exciting. That's an exciting change. But besides an actual treatment option, I would have to say one of the things I'm most excited about is kind of a sea change in our approach to the disease. We have always been kind of reactive to MS when we had weaker therapies, not these highly efficacious treatments that we have now. You could make, we can never predict where someone with MS is going to go. So we try to get there, and I want to talk about some other exciting things in terms of biomarkers, in terms of tracking where we're going. But I think one of the most important things is our approach of reacting to when someone already has a relapse. Why don't we use stronger treatments in the first place to prevent relapses and try to prevent slow worsening of disability?
Thank you. Dr. Hunter, since I know Dr. Williams wants to go
I
last.
would continue on basically what John's frame of mind is here is we have developed basically 3 classes of MS therapy, good, better, and really freaking fantastic. And pretty much the safety goes in the reverse order. But we've nearly completely left behind the first group we started with because control of disease is so critical. And we've learned that when you control disease, you make people better. You don't just prevent them from getting worse. And we've gone from talking about progressive MS as a hopeless cause to progressive MS as something we treat every day because it works. And the government had to back down and actually let us start doing that, and companies start doing that and talking about it.
All right, Dr. Williams.
Last but not least, I think the thing I'm most excited about, obviously about treatments and the advances, but I am also very excited about the focus on wellness. So we talk a lot about treatment, but there has really been a move, I think, to talk about lifestyle medicine, diet, exercise. It was so exciting to hear the presentation talking about breath work. Like, I get excited about breathing. But I think that, beginning to research and study these things and the real effect that they have on people's everyday symptoms in life is extremely important and has really been underutilized, I think, in the past. And so I'm really excited to see actual research projects about diet, exercise, movement, things like that to help people with MS.
You got Trevor really excited.
I know. We like breathing.
There he goes. All right. Next, 60 seconds each to tell us about stem cell therapy updates, transplants, and repair.
Well, I'm going to talk about
I'll let you
repair
start
because
first.
I've been doing that for 40 years. So repair happens when you stop the damage if you're younger, and when you're older, repair doesn't happen very much. So the key thing is control the MS, control it fast, control it well, because it doesn't repair very well. Taking care of your body when you're older is extremely critical to repair, we've learned. Uncontrolled diabetes, uncontrolled hypertension, tobacco, all these things destroy your ability to repair. Your brain wants to repair. It does it very well. If you wait too long, the repair isn't enough. That's what we learned.
Thank you. Dr. Williams, you got 60 seconds for this.
Yeah, so I think one of the things I find exciting about stem cell is certainly, the prospect of people having long-lasting results. I think, however, one thing that I'm a little concerned about is that there are many procedures that are being touted as traditional stem cell that are not the same procedures that we have research on, and there are many people that are paying lots of money on a regular basis for procedures that don't have the research behind them. So I think it's also important for us to make sure that we recognize that all stem cells are not created equal and all stem cell procedures are not the ones we have research on, and so just be very careful and consult with healthcare providers about it.
That's great. Thank you. And Dr. Calkwood, your turn.
Yeah, on stem cells, I'd say we have a national level trial going on in stem cells now. It's I think in almost every state. I think there's a site, so you can participate in a clinical trial. To your point, Mitzi, Dr. Williams, we've seen not only people getting stem cell treatments, various types of stem cells. They can be from cord blood. They can be reversed engineered from fibroblasts. They can come from bone marrow samples, autologous bone marrow. So where the stem cells come from is important. How they're engineered, how they're prepared, where do you put the stem cells? Do you put them in the blood? Do you put them in the spinal fluid through a spinal tap? These are all outstanding questions. And we've been waiting for the promise of stem cells to come through. The potential is clearly there. It just doesn't seem like we're quite there yet. We're still at a research level, and I think many people have been expecting more, from myself included, have been expecting more from what we're learning about stem cells. I think the promise is still there. It's just taking time, and I'm frustrated. It's like, come on already. So this national trial going on, phase 3 research is really where, when we get to phase 3 research, and we have one study going on like that now, when we get multiple, trying all these different stem cells, different methods, eventually we will arrive at some usefulness. It's helping people now. We can see in some of our clinical trials, and I think it'll be useful in the future as well.
Thank you very much, Doctor. All right, next, I'm going to be starting with Dr. Williams on this because I know that she does a lot of talks on this, but Can you discuss progress in clinical trials in MS and how diversity and inclusion are considered in these trials? You got 90 seconds.
Ooh, I can give an hour-long talk.
I
on
know
that,
you
Stuart.
can.
Okay, 90 seconds. I think the key points are we're realizing that the demographics of MS are changing over time. We're realizing that anybody can get MS. And so I think that, when we're talking about research, ultimately we want research to include the people who will be served by whatever treatment or procedure is created or is used. And so I think the focus on diversity in trials, whether it's people of, different racial ethnic backgrounds, people who live in rural communities, people who are over the age of 55. And I always say 55 is not old, even though our clinical trials say 55 is old. So I think that we have to be more inclusive to make sure that our treatments serve everybody who has MS.
Thank you very much. Dr. Hunter.
So progress in clinical trials is very important. If you haven't figured out that we don't get new medicines unless people will volunteer, you haven't been around MS for very long. It's very important for people to participate of all groups and ages. We have been limited greatly in that. Part of it was minorities years ago were abused in clinical trials, and many of them were quite scared to participate, and rightly so. That period is over, and they are really, really needed. Part of why we have MS is we have genes that are very good at fighting infection. Those genes largely came from Northern Europe, and they've spread across the world into different groups of people. And nobody is a pure African, nobody is a pure Asian, and nobody is a pure European anymore. So it's very important to understand how these genes do, and participating in these trials helps everyone learn, and we won't get where we want to go without that participation.
Great. Thank you for that. Dr. Calkwood.
Yeah, so the diversity and inclusion, especially in clinical trials, there's a lot of moving parts to this. I think research has focused quite a bit on Eastern Europe and Europe in general, which is, again, Northern European ancestry, high penetrance of MS. But a lot of the research done in Eastern Europe is on white people, very white people, and a very defined gene pool. In the U.S., we're not so defined, and yet we have research trials that still 98% of participants in a clinical trial are. I mean, there was a recent study on one of our oral MS drugs that most of the study was done in Eastern Europe, and 94% of the people were from Eastern Europe. So that's a big deal. And not everybody with MS is the same, even if you're of Northern European ancestry. And we really have to include people in these clinical trials so we understand different populations. We know that people with of African ancestry have while they're less likely to get MS, but when they get MS, it often is much more severe than someone of Northern European ancestry. So that alone is critically important, that we understand that our treatments work not just for the white people in the clinical trials, but for everybody. And we can go on and on. You can go on and on too, but we have social barriers, economic barriers that are preventing people from participating in clinical trials. So we have a lot of work to do on diversity and inclusion in our research in MS.
Okay, thank you. In talking about gaining a better understanding of MS, can you each explain why MS is different for every person? And you only have 45 seconds each on this.
I'll take that one. Nope, can't explain it.
You have to turn your mic a little bit. There you go.
Yeah, MS
seconds.
is different, and my mentor and friend, and everybody knows him, and Randy Shapiro. Randy Shapiro used to get up in front of large audiences of doctors and say, "If you've seen one person with MS," and he would say, "You've seen one person with MS." And if you think you've seen the same two people or two people with the same MS, he'd say, "You just haven't looked close enough." So the reality is it's a very different disease among different individuals. We don't know why. Genetics is part of it. There are lots of environmental triggers. one thing was brought up of lifestyle, obesity, exercise. We'll get a shout out from Trevor again. There's so many moving parts to why someone with MS, including where their MS, does their MS pick more on their brainstem or their spinal cord? The lesions, are they really occurring randomly? And some people, they cluster in certain areas. So all of these are individual factors, but ultimately, can I explain why? No, I can't.
Okay, Dr. Williams, take it from there.
Yeah, I don't know that I have a whole lot to add to that. I definitely would agree. I think just like each individual is unique, the way we experience life, the way we experience symptoms, the way we experience everything is going to be unique, and it's no different with multiple sclerosis.
Great, thank you. Dr. Hunter, you have anything to add?
Did Mark Twain ever come to Colorado? One of the things that he said that I think applies here is, as far as I can tell, he's the first one that ever said it, was he said, lies, damned lies, and statistics. There's no such thing as the average person, and there's no such thing as the average MS. MS does start 4 different ways. It usually starts with either optic neuritis, a brainstem syndrome that could also be a visual disturbance or a balance problem, or weakness in sensation problems in the spinal cord. The 4th way is you can't really tell what it is, and it's called a prodrome, and people have vague symptoms for years leading up to it. After that, it's completely different until it's really awful, and then they all look the same because their nervous system's beat up.
Great, thank you. All right, getting to the next question, very short and sweet. You got 25 seconds each. What are the 4, you got me stuck on 4. What are the different types of MS? 25 seconds each. What? That's right, that's about it. Go ahead.
So primary progressive MS, relapsing progressive, we could go through all the old chronic progressive, lots of names. Basically, we have MS that starts out slowly worsening that may have a relapse or 2, and then we have MS that is primarily defined by relapses and recoveries. I did not use the word remission. MS does not go into remission.
Yeah, so I usually say, so I do use the word remission, but I'm very careful to say that remission with MS is not like remission with cancer, right? We think if someone has cancer and they go into remission, there is an absence of disease. Remission to me with MS is a period of stability. So that means if you improve 90%, you stay at that 90% and have that 10% of disability left, that's a period of remission. I think, again, it really is now classified more into what's primarily going on. Are we having more progression is the primary thing, kind of slowly getting worse over time? Or are we having those acute episodes where things get worse and then they kind of level out? And that's kind of how we characterize in order to be able to treat people.
I would just summarize what my colleagues have said is there are relapses, which are new changes, recent changes, and there's progression, which is you can't really tell when it changed. Everybody has both. There are people who are near one end of the spectrum where one of it's more, or the other end of the spectrum where relapses are more. Everybody will have a relapse if you watch them close enough. Everybody will have progression if you watch them close enough. Progression starts even in young people early on, and relapses happen even in old people who've had progressive disease for years. It's all treatable. It's very treatable. It's a question of how hard you try to treat it.
Thank you. All right, next one is a little bit more complicated, but I'm only going to give you 60 seconds to answer it. And that is, how do you relay or explain to your patient, possibly a newly diagnosed patient, and their care partner about multiple sclerosis?
So I'll start. I spend a lot of time educating and talking to people. I like to talk, which is why Stuart only gives us 60 seconds. But I think I try to explain things as simply as possible, right? So we talk about the central nervous system, how it's affected, how your immune system is overactive. It's doing the most, as the kids like to say, and not only doing its normal functions, but also attacking you. We talk about the different symptoms, and I also try to do it in pieces, right? So there was a time where we could diagnose your MS, tell you about the 3 or 4 treatments we had all in one visit. But I think in order for people to digest, they need some time to kind of think about the information, because sometimes when I say you have MS, for them, it's over. People are, kind of devastated or crying or not really able to absorb information. So I think we have to take our time to explain that to people. I draw pictures. I use rap analogies. I use cheerleader football, rock analogies, but try to explain it in very simple terms that people can understand.
Dr. Hunter, I know Dr. Calkwood is trying to do
So
that.
I love hearing my colleagues relate these things. I tell people that a virus has fouled up their immune system. It's a common virus everybody has with MS, and almost everybody else has. And they have genes that they inherited from their ancestors who kept their ancestors alive that don't know how to stop and don't know how to forget. And it's caused a situation like acne in their brain. Don't laugh. It's really like acne. And it's not curable. And the benefit of everything we do is to prevent something bad from happening that's going to be worse. And you'll still have problems, but we're going to try to make them as minimal as possible.
All right, Dr. Calkwood.
I think, example you mentioned was in terms of a newly diagnosed individual. So I think from that perspective, you have to put yourself in the seat of the patient, and it's really a shock. I think you ask anybody with MS when you were diagnosed, and you get not just the month, the day, you get the time, you get the circumstances, what they were doing, who they were with. It's like where everyone was on, not any traumatic event that's indelibly etched. So you have to understand that they're going through that traumatic event, and they're not going to hear much of what you tell them at the time. So I don't mind repeating myself. We say the same things over and over and over again, and it can be a little overwhelming. So breaking it up a little bit. But I think the thing we have to really do is gauge where that individual is at that time. And we're always going to overwhelm them, but then give them as much as they can handle at that point. Ask them if they can take more. And then we have to do it in smaller sessions. And then we also have to gauge that individual. How best are they going to receive the information we can give them? We could give them an analogy. We could give them different examples. We could explain, if I have someone who's a little more geeky, I might get into some of the science. But I think we have to connect with that individual where they are, and then explain the disease to them where they are and where they can receive it. Then I want to encourage them to get to where they need to be. And that's through literature. What book? What's a good book? MS for Dummies. I hate the title, but various resources. MS Society literature, MSAA. So there's information out there. Newly diagnosed. I make sure they don't go to support groups unless they're for newly diagnosed people. So there's a lot that goes in, and I think we just have to be sensitive to where our patients are, and it's hard to do from this side of the desk. Actually, we really have to stop and make ourselves think about that.
And can I add one thing? I think one question that I ask every person that steps into my office, particularly those that are newly diagnosed, is tell me what you understand about MS. And that will often tell me where to start my conversation. Some people have done a lot of research. Some people have purposefully not done any research. I ask the person that's diagnosed as well as the care partner. And so once I get that understanding, then it kind of tells me where I can start the conversation.
Thank you very much. Dr. Calkwood, can you touch on the prevalence of MS, meaning about gender, race, regions, genetics? I know you spoke about it a little bit before, but it was out of sequence of what we're talking about, so I want you to bring it up again now.
Yeah,
60 seconds.
Well, MS is a disease of people of Northern European ancestry, and that is based on the genetics. You don't really inherit MS. You inherit a tendency to develop autoimmunity. Everybody's immune system makes mistakes. The difference between someone who develops autoimmunity is those mistakes that are made don't get corrected. And so that's essentially, in a nutshell, kind of what the underlying immunological issue is with MS, is those mistakes don't get fixed. Now, because of the genetics of it, it does tend to occur again in people of Northern European ancestry. If we look in the US, we can see that migration Where I am in Minnesota, for instance, we have a lot of Northern European, Scandinavian, Finns. I didn't include them as Scandinavians, by the way. But Northern European people migrated there, Germans. And we have a very high incidence of MS. We'll have 80 per 100,000 or so. So other places, I was in New Orleans for a while. We had an incidence of around 30 to 40 per 100,000. Very different populations from different parts of the world, different genetics. So that's part of it. There's so much more.
Dr. Williams.
Yeah, so I'm very interested in MS in diverse and underrepresented populations. And research over the past decade has suggested that the risk for MS may be very high and the incidence high in African Americans here in the U.S., which is really surprising because, traditionally we've always thought of MS as primarily a young white woman's disease. So I think, our understanding is changing. One of the limitations here in the States is that we don't have national registries because obviously we're very concerned about our privacy. But in other countries, they have actually a national registry, where everybody with MS has data in that registry, and we can understand, who's getting MS, how they're being treated, where they're being treated, et cetera. And so we're trying to get to that here in the U.S., not a registry, but get that information in other roundabout ways, and it's helping us to better understand how to serve the MS population here in the States.
Thank you very much. Guess who's next?
Lies, damned lies, and statistics. So when I did research in Dr. Calkwood's neck of the woods 30 years ago, I pulled out the numbers in the laboratory, and I said, oh my God, 1% of the white women have MS. It's actually even more than that. My colleagues in Rochester, Minnesota have scanned people on the street, and they say 3% of everybody looks like they have MS, but only 1% of people know they have it. So we know that this disease is a close call for many people, and the severity is very unpredictable. We know over 1% of white women will get MS, and a lot of people who are not Caucasian in their race. We know that vitamin D has a huge impact, a tenfold impact on who gets MS. And that's part of the genetics, is the genetics drive vitamin D levels down. Why? It was a trick your ancestors used to stay alive long enough to have children. We know that this virus EB is required to have MS, and it's a crafty, ancient parasite of the immune system. But why did you get MS? Are you listening? Listen, I'm going to tell you, bad luck.
Thank you. Great answer. All right, moving forward in looking at communication, and I'm going to ask you each to stay to 45 seconds, okay, because we have a lot of questions remaining and we don't have a lot of time on the clock. All right, so first one, what do you find specifically works in your practice when communicating with patients and family members?
I kind of touched on this already, but I think the other part of that, of communication, so listening, right? Listening, right? Communication's two ways. Often I find myself realizing I've been talking to my patient for 5 minutes and they hadn't said a word. So I need to check in with that and kind of understand. So communication is a two-way street. We have to listen. We're very busy and we have a lot to communicate to our patients. But it's really important to know what it is that you want us to communicate. So not only do we have to listen, we have to ask you questions. What do you want to know?
Very good. See, they listened.
Yeah, and right in line with that, I mean, that was awesome. And right in line with that, I think for me, empowering my patients is extremely important to me. I don't want people to just come and kind of passively sit in the office and I tell them what to do. I want people to do their research. I try to direct people to resources, that would be helpful for them. I try to encourage people to bring their list of concerns so we can make sure we address what needs to be addressed during that appointment. So I think that, that listening and that two-way communication, but also empowering people to bring their concerns, right? So that you don't leave the office and call back and with those 5 questions has been extremely helpful and helps us to really partner and have a real shared decision-making process in the clinic.
Great, thank you. And Dr. Hunter?
So I think the most important thing I can do is get people thoughts that are succinct and helpful and help them understand that they can play over in their head, that whoever is the partner who's there in this experience with them can help replay to them. I call these therapeutic thoughts. And it's very important for people to understand what the priorities are here. There are some symptoms of MS that are extremely troubling and distracting, but really don't matter in the long term. These things like fatigue or tingling or some dizziness, or some minor blurriness or minor double vision. These are not where the money's at in terms of treating the MS. And people have to understand that the things the neurologist sees, the balance, the strength, the sensation, the quality of the function of these things are where the disability is going to come from that's going to cause the trouble down the road. And being able to communicate that and the nature of pain, and that pain is just a pain, and you're going to treat that, but it's not the game here. Getting them to understand the game that you're playing is really important.
Let's move on to understanding what is a comprehensive MS healthcare team. All right, 60 seconds each. I'm going to ask Dr. Hunter to go first. Can you please explain in the most ideal circumstances what a comprehensive MS team would look like?
You need a good primary care doctor, you need a good neurologist, and you need a good specialist for every single thing that ails you if you can get to them, because nobody can do the whole show. Neurologists differ in their skills, primary cares differ in their skills. But, I mean, if you have a bladder problem, you need a good urologist, somebody who likes to deal with your problem. If you have a vision problem, you need a good ophthalmologist who wants to deal with your problem, not just somebody who's farming your cataracts. You need somebody who cares about it. Same thing with your bladder. They're not just looking for kidney stones. They're looking to make you happy. You know, if you need rehabilitation, you need somebody like the gentleman who did the presentation here, somebody who's excited about getting you better. You know, that is hard to find. You can't find the entire team in one place. That's not going to happen anymore. It has to be a clinic without walls nowadays.
Thank you. Dr. Williams.
Yeah.
Go ahead. Clap.
Yeah.
Go ahead. Let him clap.
Yeah, so I agree. I think definitely I would echo Sam's sentiments. You need a primary care physician because your neurologist doesn't want to look in your ears and nose for your sinus infection. And then I think also mental health is extremely important. So I emphasize a lot of work with mental health specialists, whether it's licensed counselors, psychiatrists, psychologists, because dealing with the diagnosis itself can be very difficult. And then when people meet certain bumps in the road, if you have a relapse and symptoms don't resolve, you know, they're all new issues, changing of roles and families. All of those things need to be addressed. And mental health, I think, is equally as important as your central nervous system health. So that's one additional piece I would say is important.
Okay, and Dr. Calkwood, you got this new center going. Great, thank you.
So if we're talking about ideal circumstances of what a comprehensive MS team would look like, I agree with all of the external. If we talk about the internal, so the internal to the MS clinic or the MS center, well, first of all, it revolves around the patient and should be very patient-centered and patient-focused. Now, we patient-centered and patient-focused with nurses. Quite frankly, nurses are the lifeblood of an MS center. We manage a lot of primary care over the telephone. Patient calls up, I've got a bladder infection, my doctor doesn't want to treat it. We treat it. We know what happens to people with MS if they have a bladder infection that's untreated even for a short period of time. So I think having that ideal team is having the right people within your team, but it really is centered around that nursing care so that we can answer your calls on the phone. Often we get the experience in healthcare now, you call your doctor's office, they just make you an appointment, they don't talk to you. Maybe you get a refill or something like that, but pretty much in the office, face-to-face. We do a lot of care that is not face-to-face, and our nurses have to do that. Our patients have so many complicated issues, and they span multiple lines. You've heard of the different specialties we've mentioned here. We need as an MS specialist, we need to be knowledgeable enough about those subspecialty areas to know if our patients are getting good subspecialty care. We need to coordinate with those members within the community. So a comprehensive team is not just about internal. Those connections are internal. Our nurses, our nurse practitioners, it is a team in the MS center. And internally, ideally, we have to communicate amongst ourselves. So if my nurse practitioner sees someone who's having a problem and I see them a week later, I know what's going on and I have follow-up, there's continuity. Or my nurse practitioner discusses that with me. Or we set up a telemedicine visit, using every possible way to meet and reach patients where they are. Reaching out in the rural communities. If they don't have telemedicine available in the rural community, we call them on the phone. We do what it takes. That's what an ideal MS team is about. And it's the people taking care of the person with MS. And while it starts with the nurses, let's also not forget support partners, hugely important, critical piece of what we do.
Okay, thank you for that. Round of applause. We're not done yet. We're not done yet. No, we're not done yet. All right. So if you do not have access to an MS center with a comprehensive team available to you, what would you recommend in place of this, and how does telehealth get involved as well? And Dr. Calkwood, you can start first. 45 seconds.
Yeah, I think on the telehealth thing, there's part of the sort of underserved community that and rural in Minnesota. You can go third ring suburb outside of the Twin Cities, and you just don't have broadband internet access, the technology available. And that's whether people are underserved by their physical location, maybe they're underserved economically. So I think that the ability to really connect with people in face-to-face and extending that ability through telehealth is huge. Also to connect with the support partner, connect with loved ones, having them available. We often have blended visits where we'll have a telemedicine, or if someone's got to work, bring them in on the telemedicine system while the patient's face-to-face. So being nimble there, taking every opportunity, using technology while we're allowed to. I for one, am very glad that telehealth is not going away. I think we're going to see more restrictions placed post-pandemic, but I'm very happy that it's here and here to stay in some form. It's great for our underserved patients and persons with MS.
Thank you for that long 45 seconds.
I would just add to that in terms of, I think that if at all possible, at least once during someone's journey with MS, they should try to see an MS specialist, right? I recognize that certainly it's not something that many people can do on a regular basis, but I think that it is an important investment, at least to have somebody kind of review your care plan. One of the things that I do is I co-manage a lot of my patients. So I have a lot of folks who see me from hours away. They may drive or they may fly. And because I'm able to do telemedicine, I'm able to kind of check in and see them periodically, but they also have a local neurologist. And so I think that, that sharing care model is extremely important, where there's someone local that can admit to the hospital or something like that, God forbid that happen, but also you have that specialist that you see periodically, whether it's once a year or once every other year, or at least once, to help review that care plan, particularly with all the new treatments that are available. It's important to have somebody who's really on top of that.
I have some very bad news about telehealth. For Congress, the Congress of the United States gave us a lump of coal. The DEA set out to completely restrict neurologists from prescribing any medicines that are considered controlled substances over telehealth. It's gone already. You just haven't heard it's dead. We need telehealth. We can't do without regular visits, but we need telehealth for people with MS. You need to write your legislature. You need to write and complain, because they've taken it away from you specifically. They let psychiatrists do it. That's the only one they let do it. And they won't let them prescribe half of the medicines that you need to treat your MS symptoms over telehealth. Write your congressman today. It's already dead. You just haven't heard about it yet.
Stuart, I'd like to do one follow-up because I didn't really address, I think, hitting that underserved. I got 20 seconds for a follow-up. Talk fast. Okay. So one other thing I think that's important, is, we have a lot of people on infused therapies now who are regularly going into infusion centers all over the country. Upwards of 40% of people with MS now are on infused therapies. We could do better by providing services for those patients where they are. Something as simple as getting a JC virus blood test, if you're on a drug that has PML as a risk, is really difficult in some regions to get a simple blood test that is the primary driver of safety for that particular treatment. So providing and developing those services, if you're on an infused drug, why can't you have your labs done? Why can't they be drawn right when they start the IV? Why can't we do some measurements of your MS while you're there? You're there every 6 months. We can do a timed walk. We can do a coordination test, 9-hole peg test. We can do a cognitive screening test. It takes about 10 minutes. We can do that while you're at your infusion visit. So that level of coordination would allow people in underserved areas who don't have neurologists who are MS experts to get some of that expert level data to help them manage their patients. So I would do a shout out for that. That's something I would like to see.
Thank you. Thank you much. All right, getting on to the next thing. Let's talk about recognizing and managing MS relapse. I really need you to keep your answers short. All right, first question. What are common experiences related to an MS relapse, and how would you best want to see someone who feels they may be experiencing a relapse communicate better with their healthcare team? And Dr. Williams, I'm going to ask you to go first.
If you're having problems, call. So I tell my patients, particularly when they're first diagnosed, oftentimes people can become a little hyper aware of their bodies and everything that's happening. It's like, oh, my eye is twitching. And I'm like, yeah, well, mine does that too when I look at the computer too long. But over time, you get a feel for your body and what your normal is and you're not normal. If it's not normal, call and let somebody know, right? The worst that could happen is we say, oh, I think that, you stayed out in the sun too long, or maybe you have some type of infection. But if it's a relapse and it needs to be addressed, then we're able to address it. But that is better than you waiting until your 6-month appointment and then coming in and saying, oh, by the way, 3 months ago, I had this problem. So, I think particularly with, the treatments that we have available and our ability to kind of course correct and change treatment, it's important for us to know when people are having symptoms and issues. So call if in doubt. If you're not at your baseline, call and let somebody know.
Okay, Dr. Hunter.
So I want to address the issue that is common among MS patients, where they feel like they have to proactively treat a relapse right now before it gets worse. You can watch most relapses. They are not emergencies. If you feel you have an emergency because something horrible is going on, you have an emergency, and it may not be an MS relapse. It may be an infection. You need to get checked out and be sure you don't have an infection. Somebody else on a highly effective treatment don't get relapses very often, but they do. And they need to be seen. You're going to have to be treated if it's significant enough. And what the neurologist is going to do is decide whether your relapse warrants treatment, first of all, and second of all, how to treat it. It's gotten very, very, very hard to get IV steroids. Why is that? Your insurance companies do not pay for it. They either pay for it and then they take it back, or they pay about the same amount as you tip a server at a table. All right? You can't operate a highly efficient system to deliver healthcare for what you tip a server for. Okay? So you need to complain about that, but there are other ways to do it. So you have to establish a good care if you want to be able to have access to those services. COVID's wrecked the healthcare system in a lot of places. And, you want to get on a highly effective treatment that's going to help prevent the relapses. You want your relapses to be ones that need to be treated, and don't just call up your doctor and say, I think I need treatment for a relapse. You show up in your doctor's office first thing in the morning, get an exam, see what's really going on. Steroids are the worst thing you can do for your immune system. It's the best thing you can do for a bad relapse.
Thank you. Guess who?
So, relapses are important. not just to treat them, we count them, we track them. A relapse will tell us if your treatment is being efficacious the way we want. So we need to hear about them. So my rule of thumb is if you have new or worsening symptoms lasting longer than 24 to 48 hours, call me, message me, send up smoke signals, call my nurse, do whatever. Get a hold of us some way, shape, or form. Let us know that something is changed with you. Now, that rule of thumb is a little tricky because if it says you have a brand new symptom lasting longer than 24 to 48 hours, and it's like, yeah, but my right leg is tingling now, and it used to be on my left leg. Yeah, if that lasts longer than 24 to 48 hours, call me, call us. Let your doctor know, let us decide. Yeah, we may want to see you in the clinic, we may need to do an examination, but that's where it starts, is you communicating with us. So 24 to 48 hours and a relapse symptoms are going to build. So it will get worse, it will get your attention. Please let us know.
Fabulous. Thank you. We have 5 questions remaining, which will probably take another hour. It's like the end of a football game, right? So it just goes on and on. All right. So next, will telemonitoring tools like apps be part of the MS care path in the future? And what would be the biggest value of this? Dr. Calkwood, 30 seconds.
Yeah, I think right now, yes, absolutely. The more data we can get about you when you're not with us, when we're not seeing you, we can do your neurologic exam, we can track you, we can measure how quickly you can walk, we can measure coordination, but we can't be with you all the time. So apps that track your activity level, your physical activity level, absolutely, I think that's going to be helpful. Biomarkers, another very, very interesting emerging field where we are able now to do blood tests that will tell us, so laboratory biomarkers I should specify. We can do blood tests that will tell us or warn us. We have a blood test that we can do if we're not sure whether you're having a relapse or maybe it's an infection causing your old symptoms to worsen. We can do a test called neurofilament light. There's a whole bunch of biomarkers. Pay attention. A lot's changing. It's coming really fast. We're going to be dealing with biomarkers very soon that are going to be able to help us manage this disease and stay in front of it instead of reacting to it.
Thank you. So you actually got into my next question after that as well. So therefore, I'm going to now ask the remaining to answer also about the telemonitoring tools, okay, and the apps, what you just heard, and also tell us more about the blood and the CSF biomarkers that are out there. And so Dr. Williams, can you go next, please?
Yes. So I agree that, monitoring how people are doing at home is extremely important. I think one of the things that may be difficult is figuring out how we can, as healthcare providers, integrate that in some meaningful way. So if I haven't seen you in 6 months and you bring me an app with 6 months of you walking and, how do I translate that into something meaningful? But I do think that it's important because you always look good when you come to the doctor, right? So everything is perfect. Nothing's hurting. Everything's great when you come to the doctor. I think in terms of biomarkers, this is also very exciting. We're always looking for the holy grail of blood tests to tell us about what's going on with your MS. Because obviously we can't do an MRI, on the spot every time you're having issues. And also, obviously nobody wants a spinal tap ever again if they've had more than one. So I think that the blood biomarkers are exciting because they have the potential to tell us how your MS is going and also to give us additional information about how your treatment is working and help us to determine if your treatment is correct.
Unfortunately, no blood test is ever going to detect the minor MS relapses. It's certainly going to detect people with dangerous activity or smoldering activity, which are important things to treat. If you don't have a neurologist who is willing to examine you, you have a problem. You may be able to solve that by saying, aren't you going to examine me? Aren't you going to watch me walk? Aren't you going to check my sensation? Aren't you going to look at how my eyes are working and shame them into it? but some are helpless. Okay, so you need somebody to examine you to tell if you have a relapse. If it's not like horrible, go to the hospital kind of relapse. This is a device. It's made by our great friends in the neighboring state of Kansas. It's worn by many Coloradans when they climb mountains to keep track of all their physical activity and what they do and what they sleep. It's an amazing device. It's better than anything that medicine's going to improve and tell you what your body's doing, because basically you can learn a lot about what you're doing just from observing yourself. You can video yourself. You can show the doctor. You can count your steps. You can look at your sleep. You can see how much you're moving. You can see how fast your heart rate's doing and how you feel. That information's out there right now. You can take advantage of it. That's information that your doctor can use. There is a limit to how much healthcare you can get. You have to choose what's most important for you. Getting smart about that's the best thing you can do.
So that being said, in real short, are there any apps out there that support patients' memory so that there's more data available during a clinical visit? What can you tell us about that, any one of you? Okay, then we'll go on to the next thing.
Yeah, no, I think what deserves attention is that I'm not sure it's any one particular app, but attending to the issue. If you have cognitive issues, work on your cognitive issues. And the brain, we're learning, is much more like a muscle than we used to think. You can work it out and it will get stronger. So whatever your deficiency is, if it's a cognitive issue, you're best off, rather than an app, maybe an app is part of a tool, and you work with an occupational therapist, and you get an individual assessment for what your issues are, and then we can tailor it. Then the app might fit, or so I think, yes, there's a role, but I think it's part of a broader treatment approach.
Thank you. You want to say?
What Trevor said is that you move.
I knew you were going to go there.
That is the number one thing. That's the number one, the number two, the number three, the number four, the number five thing to solving a cognitive problem.
Okay, thank you. Let's go on to the third to last question. Priorities and goals in living with MS. In seeing so many individuals impacted by MS, what are your recommendations to patients in regards to setting their goals and priorities in both their personal life and in personalizing their treatment plans while living with the disease? Dr. Calkwood, 45 seconds.
So I think prioritizing in setting goals is definitely important. And it sort of depends on where the individual is. Early on in a recent diagnosis, I think the priority is really just helping people to kind of get their feet on the ground with their disease and understanding the disease, understand that there are treatments, and that no, you won't always feel like this. It will get better. A new normal will emerge. I think that is certainly one of the issues. The goal setting. It's not a single goal. Your goal might be to not become disabled, but it's a series of goals. And more important than goals, it's a series of choices. So you may have a goal, but the choices you make is what really is going to determine whether you get there. And many of those are lifestyle choices, quitting smoking, exercising, taking care of yourself, losing weight. These are all other important things that people can do to help themselves. And so I think that's what I would say, rather than an overarching goal, maybe it's a series of little goals to reach your ultimate goal of not succumbing to disability from this disease.
Yeah, what I would add is that I think, number one, it's important to remember that you can set goals, right? That a diagnosis with MS, I always say, is not a death sentence, but is an adjustment sentence. So maybe we may not be able to reach all of the goals we previously had, but there are still many things you can do and many goals. I've seen many of my patients do amazing things following diagnosis, and it may not be the path that they originally picked, but they still have very fulfilling and amazing journeys. And I think the other piece is that I would say it's important to work with your healthcare providers to also set realistic goals, particularly in terms of treatment. I spend a lot of time educating that our MS treatments do not necessarily improve the symptoms that are there. They don't fix what's broke, so to speak, but hopefully prevent new things from being broken. And I think that's something that is a little bit difficult to grasp in the beginning, because usually we think you take a medicine, you feel better. And so I think sometimes there's disappointment because the goal for many people is, if you take this medicine, it's going to help my leg move or help me get out of this chair or help me do that. And there are many other things that may help accomplish that goal, but the medicine itself may not necessarily do that. And so I think it's kind of reconciling that in the beginning is extremely important.
I think it varies depending on where people are in life and with their MS. Early on in MS and in life, it's all about controlling disease. Later on, it's like managing with disability and making sure people cover all their bases for healthcare. And when they really have a lot of disability, it's about keeping what they have. And being able, I mean, if your legs are in bad shape, you've got to have your hands. If your hands are in bad shape, you've got to have your swallowing and your vision. There's always a place to focus the energy for MS care.
Great, thank you. Next, getting slightly off the MS topic, but bringing up a very important topic that has been getting more and more prevalent, is to talk about NMOSD. I need you to really stay short on this. Okay, so we can get on to our overall questions, all right, and get to our final speaker of the night. So first, what can you tell us about this rare disease called NMOSD and its initial similarity to multiple sclerosis? Dr. Williams, 30 seconds.
Yes, so NMOSD used to be considered a part of multiple sclerosis or a subtype of MS. It essentially is very similar, except it primarily affects the vision, the optic nerves, and the spinal cord. There are some cases where the brain can be affected, but the lesions are not quite in the same spaces that we see with MS. Also, the vision changes can often, or the relapses can be very devastating, with very poor recovery in some cases. So it's extremely important with that disease to make sure that it's diagnosed accurately and that it's treated effectively. And that's where I'll pause.
Dr. Calkwood, true 30 seconds.
So it used to be called Devic's disease when it was considered a type of MS. And then an antibody was discovered, actually at the Mayo Clinic. They discovered an antibody causes it, where MS is not driven by antibodies, it's driven by T cells. So that was one of the first things. Yes, it attacks the optic nerves and the spinal cord, devastating attacks. It's not like MS. You could be one and done. One attack can put you in a wheelchair the rest of your life with NMO. It's a really challenging disease. Doesn't respond to the same treatments that MS does, although there's an overlap with a couple of our treatments in the B-cell arena. So it is a very challenging condition, and managing the symptoms, we manage the symptoms the same way we manage MS symptoms, but it is a different disease and doesn't respond to the same therapies.
We look for it a lot. It's about 1% as many people who have MS. You can have what looks like MS for decades, and it's actually NMO. You can have NMO, and it's hard to tell that it's NMO because it doesn't have positive tests for it. Everybody's different. But it is something that only takes and never gives back. It's a devastating disease when it's there and it's going. It's very possible that your neurologist doesn't recognize as NMO because it's not recognizable as NMO, and that's true half the time. It acts just like MS in many ways. It is not easy to treat, but you have to treat it with much more medication than you treat it with MS. You think steroids are your friend, they're vital to saving your life with this disease because you won't survive without a lot of them. But it's much worse than the average MS patient.
Thank you very much. And in closing, if you could relay one important message to the active MS community here tonight and those watching online, what would it be? And I'm only going to ask you for 30 seconds each.
I'll go. I think it's the same message I always tell everyone. You are your own best advocate, you and your care partners. And, we talked about healthcare team earlier, but it's important to remember that you are a part of the healthcare team. The healthcare team is not us up here by ourselves. You are a part of that team as well as your family members. And we can't treat and manage MS without you being an essential part and at the center of every conversation about treatment.
Dr. Calkwood.
I think I would just say very slowly to irritate Stuart a little bit that yes, advocating, and you stole part of my answer, but no, actually it's a good answer. Advocating for yourself, but understand this, time equals brain in this disease. This whole flip we're in the middle of doing, of being proactive with your treatment. If there's one message I'd like to get to the MS community, advocate for yourself, but advocate for yourself to be on the most highly efficacious treatment you can be on safely and tolerably, because time equals brain.
And I would continue that thought with it. The person who tells you your MS isn't bad enough to treat, you don't need treatment, your MS is burned out, I'm not sure you had MS anyway, this is your enemy. Do not listen to this person. This person is going to hurt you.
Thank you, panel. So you don't get to move yet, because now we get to run around out there and I'll take everybody's questions. So I need you to raise your hands, all right? Let me recognize that you have a question, and then I'll get over to you. And by the way, everybody, for those that don't know, I too have MS, all right? And I do it, and I get empowered by doing these programs for all of you and everybody around the United States, and that's why my MS is at bay. All right, I'm going to run out there.
I have so many questions, but I'll just ask one. How much promise for PPMS do we have with the BTK inhibitors and stem cells?
That's two.
Promise of stem cells, as I said, I'm still waiting. We're seeing incremental progress. BTK, for primary progressive in particular, there is a head-to-head trial currently going on with one of the BTK drugs that is also against the only efficacious treatment, at least proven in a clinical trial, B-cell therapy. Ocrevus is the only drug that has been shown in a clinical trial to treat primary progressive. And there is a head-to-head study ongoing, but we don't have data yet. So.
The biggest problem with PPMS is the FDA has told the companies that are testing medications that they have to test only people that have positive spinal fluids, which excludes half the people with PPMS. They've also told them that they have to test only people under age 55, or they're not going to approve their drug. Half the people who have PPMS are over the age of 55. This is, our government is the problem. Let the government hear it and they need to require that companies do these tests in older people who have negative spinal fluids. This has been a problem for the last 15 years. We're lucky we have anything approved for PPMS at all.
Dr. Hunter, the spinal fluid issue, too, I'm glad you pointed that out. That's starting to make it into the vernacular of the insurance companies now. So we're now starting to see those things in Minnesota where before we can treat someone with primary progressive MS, they're asking for, a couple of insurers have asked for lumbar puncture results, which is, beyond the pale. That's where your insurance company suddenly becomes your doctor. They're diagnosing you, and not to mention telling you what treatments you can have when they don't have a medical license.
Thank you.
Hi, I have a question about the drug ATA-188, which is the it is correlation with Epstein-Barr, and which I had very severely when I was young, and I've heard about it, and I'm anxious to get on the drug, and I heard it's on hold, and I'm wondering if you guys know anything about it.
No, these are engineered cytotoxic T cells that go after Epstein-Barr virus infected cells, which are not actively infected. This is an experimental treatment that's been used to treat a really rare complication of cancer, which is called Epstein-Barr virus lymphoma. It's very effective for that purpose experimentally. This is at the earliest stage that drug can possibly be at. There have been a handful of people who have had dramatic responses to the treatment. You have lots of proven therapies for your MS out there. This is 5 to 10 years away if it's successful. I've treated people with this. I'm very familiar with it. It is very fascinating. It may be something wonderful. It may be a complete flop. We'll know in the next 2 years if there was some glimmer of hope for it, and there will be a lot more research. I hope that everybody would consider participating. But right now, it is a hope. It is not a proven therapy for MS.
All right, thank you. I'm going to go on to the next question.
Hi. Particularly from a caregiver stance, being in the room with a dismissive doctor and how frustrating that can be, and talking about collaborative care and coming from a place where we had a good system and now it's a brand new world. And to be in a room with a doctor who looked at the screen for 95% of the time. But when you talk about patient assistance programs, when you talk about insurance, who's going to write the prescriptions, how do you break through the wall of ego that exists? And I guess my real question is, if this were your daughter, what advice would you give her?
Fire your doctor. So we talk a lot about firing your doctor, right? Certainly there are sometimes areas where it is very limited, where there are not a lot of neurologists. But in many areas, there are multiple neurologists. A lot of MS is taken care of by general neurologists, and there are many amazing general neurologists who care for MS. And I tell people to take the same approach as you would with, any other team. We have all kind of teams in our life, right? You got a team of people that make you look good, cut your hair, do your nails, right? If somebody messes up your haircut, you're not going to keep going back, right? And letting them jack up your hair.
But your hair grows back.
Right. Once your hair grows back. But you will, tap into the resources you have. Ask your friends. Look in the communities. Who's your doctor? What are you doing? And if the person that you have is dismissive and is not taking good care of you, it's okay to get another opinion and to get another doctor. So you're not just stuck with that one person.
Doctor's advice is cheap would be my quick way to say it. But if you want to try to convince a physician, you use I statements. And I don't know if you have dealt with I statements, but I statements basically are saying how you feel, okay? So they're less confrontational. You can't burn through all the good doctors on the planet in the first 3 years of your MS. So it's really important to try to enlist people to help you and realize you got no idea what a nightmare it is right now for dealing with trying to get people on a brand name MS therapy. It's a nightmare. It is ridiculous. It is absurd. You are seeing the face of how physicians are responding to that. But you're going to have to make that argument. Get in there early, only deal with one thing at a time, don't have a lot of demands, and put your punches where they matter. Let them know how you feel.
As the wife of this one, I've had this 16 and a half years, and I appreciate everything that you guys have said, and I think you've been wonderful, and I wish you all three were in Colorado. Unfortunately, you're not. But MS centers are kind of like sororities here. We don't have the opportunities that we had in New York, where you can go. I was in the phase 2 stem cell trial in New York. I'm very fortunate for that. But we don't have that opportunity here. So this is not the same as one of those states where you can just go, and I understand you're not in those states either. But it is like a sorority. So if I break up with that boyfriend, I'm seeing his other boyfriends. And they're all collaborating on my care. That is uncomfortable. I would like to be able to go to a doctor that I feel comfortable with and not see someone that I just don't feel comfortable with. and then know that my doctor has to collaborate with that person again. There's no break in this state. And I'm not new to this game. And I don't mean that in an offensive, I know what I'm doing. I don't have white coat syndrome. I don't have any of those things that I've been accused of in this state. But the question is, how do we make those less sorority-like? How do we make it that we can go to one of those centers and just start new?
I mean, so I think it really depends on the environment. So I live in Atlanta. There are 4 MS centers in Atlanta. And we often have patients who may be at one center and may go somewhere else. And I don't know that, I don't know that I would, or I won't say I don't know. I don't necessarily treat people differently because they came from another doctor, and I still collaborate and talk to them. And I'm like, hey, Miss So, I have one patient who sees me and one of my friends, and we both work at MS centers. I'm like, hey, did you see Miss So-and-so? She's like, yeah, I saw her last week. I'm like, well, I've seen her next month. So I think that sometimes the perception is that, people will be, and some people may be upset if you go from one place to another. But at the end of the day, you have to be in a place where you feel comfortable. If you have a conversation with your provider and tell them how you feel and that behavior doesn't change and you don't feel supported, then they have to be okay with you seeking that care somewhere. And I think that all of us recognize that, I'm not necessarily everybody's cup of tea. And so if you feel like somebody will support you and listen to you in your journey and that person is a better fit, then I, as a doctor, want you to be in the place where you have the best fit. And if that's not me, then I'm okay with that.
First of all, I'm really, really sorry that happened to you. It just hurts me to hear things like that. Yeah, we all have bad days, and I'm sure I've probably been perceived as being dismissive and maybe was at some time or a bad day. But if this has been a consistent issue you've had, I agree. You have to find someone you have a relationship with. This is a chronic disease. You may go through your life with MS, you might go through a few neurologists. We get old, we get sick, we retire, stuff like that. But it's a real problem. You have to have that relationship where you're comfortable telling your neurologist anything, well, almost anything. We don't want to hear it all, do we? We want some of it, but we do hear it all. We do. So that's really, really important. The practical part of this is more challenging because, yes, there are a limited number of MS specialists. I would say it starts by conversation. If you can't engage your dismissive physician in a conversation about, and maybe the word dismissive, like I statements, find a way to do it non-confrontationally, but you have to engage in that conversation with them to say, I feel dismissed, or I feel like I'm not getting as much out. Now, if your doctor will engage you then maybe the relationship could be mended if, first of all, communication. So he has to listen to you, he or she, you have to listen to them, and then you have to communicate. And if that isn't there, then you have to find someone else. So your choices of finding someone else would be to, if that neurologist is a specialist and expert in MS, ask them. Who would you recommend would be a better match for my personality?
Thank you.
As an example. So, and I'm done now. We can talk later afterwards because I have some other thoughts for you as well.
Thank you. Last question from out here, then I got to grab some from online.
Since most clinical trials age out at 55, what can the MS community do to increase that age limit?
Congress. You can email them. You go online. You can email them all with a single email. You get your friends to do it. We got a medicine approved for MS about a dozen years ago that way, after a bonehead bureaucrat tried to shut it down. 10,000 signatures on a petition. Somebody got fired in the federal government. The boss doesn't like to get called to Congress and asked, why is that happening? They're really big right now on this inclusion, and they're excluding older people. And the pharmaceutical industry doesn't want to deal with them either, because it's harder to treat those people, because you know how many heart attacks they're going to have inside an MS trial? They'll probably have 10 if they include somebody. They're going to put heart attacks on as a side effect if they do that. They don't want to do that, so they go along with it. But the government needs to be making that happen. All right. There are people in this area. Some of you probably see the guy who goes around telling everybody nobody needs treatment over 50 with MS. They have data, lots of data that says that's not true. But why? They want to do that. You make a lot more in medicine if you shake people's hands, say, I'm not going to do anything for you. You make a lot of money like that.
I would say also look at organizations like I Conquer MS, right? There's a move for patient-powered research. And so raising those questions and issues and avenues where organizations can get funding for research about topics and things that are extremely important to you as members of the MS community can also help fuel that increase in, so if somebody looks at it and we get that data, then that will help larger groups of people to look at it as well.
So briefly, Stuart, first of all, didn't bother me at all that the age cutoff was 55 until I was 55. Right. Then was like, wait a minute, I couldn't get an MS clinical trial, something's wrong here. So no, it is a big issue. I think the move is already underfoot, and what Dr. Hunter said, absolutely support it. What Dr. Williams said as well, support it. The move is underfoot. We're talking about not just underserved, under less researched, less representation in research studies. The FDA is paying attention. So regulatory bodies besides Congress, that's another place to make your thoughts known at the FDA and through your society, the MS Society, the MSAA. These are all where you can unify and have a voice that is amplified when all of you speak at the same time.
Okay, thank you. I'm going to ask some questions from online, but I'm not going to ask for each of you to answer. I'm going to give one question to each of you so we can get through these a little bit quicker, okay? All right, first one. What are the updates on clemastine and myelin disease?
Doesn't matter. I was just asking, is it clemastine and remyelination, I would assume, is what they're talking about?
Maybe. I'm only reading what I read.
That's what I'm going to go with. And actually, I might need Sam or Mitzi to chime in here too. But surprisingly slow. I mean, we had some what looked like early kind of phase 2, phase 1 wins in terms of research trials. But while we can document that we can actually show remyelination and in the visual system at least be able to measure some improvement, proof isn't in the pudding. People don't notice the improvements. But research is still ongoing, so I'm not giving up.
All right. Nope. Remember, each one gets a separate question, all right?
What are they saying, Congress?
It doesn't matter.
I get all right.
It doesn't matter. All right, next one. Dr. Hunter, is myelin repair coming?
Well, that was what I was going to say. Myelin repair always happens. It already has happened. It happens all the time. It gets worse until you're older. Just like everything else, it fails. It's part of what causes progressive MS. Progressive MS is much more than failure of repair. But the more damage you have, the less well the myelin's going to repair. The older you are, the less well it's repair. The worse blood pressure you have, the less well it repair. The worse diabetes you have, the less well it repair. The more you use tobacco, the less well it repair. It gets better when you shut down the inflammation. The more omega-3s you have, the better it will repair. The more you control the inflammation, the better it will repair. The freaking amazing medicines like Limtrada and Ocrevus help it repair. S1P agents like Gilenya and Zeposia help it repair. All these things help. It goes on all the time. Every drug that's miraculous in animals to do this, it's already happening in people. That's one of the reasons it's hard to show. And there's a lot of damage that isn't due to myelin. You know, there's a lot of axons that are gone. We can't repair that. We can only prevent it.
Okay. Next one, Dr. Williams, please keep it short, right? One of the doctors mentioned that MS is part of the group of immune system diseases. What is the prevalence of MS with people with MS and other autoimmune diseases like thyroid, Hashimoto disease, or anything else that might be related?
So I don't know the exact numbers. Do you know the exact numbers? But
It's 15 to 20% for Hashimoto's, and people with MS, it's 3% for Crohn's disease. It's 2% rheumatoid arthritis.
Okay, good. Thank you.
see, my answer was short.
Well, that was good. Thank you. All right, next. Disabling fatigue and decreased cognition are the most popular concerns of MS patients. In support, are there any specific randomized controlled trials that show any disease-modifying drugs of how they affect these? And if not, why not? Dr. Hunter.
Affect what? Fatigue,
and
yes.
cognition.
Yes, there's good data about it. There's data about, for S1Ps, there's data about fatigue, cognition, and mood. And depends on the drug as to which data you have. But it's pretty clear that those agents act like antidepressants and cognition stimulants.
Okay, thank you. Last question. Do any of the MS medications that are out there help to protect against cognitive loss?
Yeah, so I think when we look, I mean, obviously, if we preserve the brain, we're going to protect against cognitive loss, right? When we think about cognitive dysfunction, one of the biggest markers that we look at is brain atrophy or shrinkage. Your brain shrinks over time. Sorry, fellas, yours shrinks faster than the ladies. But with MS, that's accelerated. And so many of our newer therapies are looking at measures of brain atrophy, particularly in certain parts of the brain like the thalamus, which can be directly correlated with cognitive function.
Okay, thank you, everybody. This was awesome, right? So again, though, for tonight, I do want to thank our sponsors. I mean, it was very important. It was very nice that they were here with us. And our sponsors for tonight, we had Sandoz, Bristol Myers Squibb, and Genentech. So let's give them a round of applause. And let's say good night, world. It's late, especially for those in New York. Oh my gosh.